You're listening to the Physio Matters podcast, this month in association with Co-kinetic, and this is session 27. Welcome back to the Physio Matters podcast for another dive into the world of evidence-informed clinical practice. Last month, Jack March brought you one of our most game-changing podcasts to date with the National Ankylosing Spondylitis Society. Several services have been in touch to discuss changes in their guidelines and pathways, as well as several patients reaching out to us on social media, expressing their delight that physios and other professionals are pushing for increased awareness of inflammatory back pain. This month, we make a move towards the world of endurance sport and discuss iliotibial band syndrome. Earlier this year, myself and Brad Neal brought out two articles with online and print publishers Co-kinetic, formerly SportX journals. Brad wrote a narrative review on ITBS syndrome, and I followed it with a case study describing a clinical reasoning journey. Subsequently, Co-kinetic have partnered with Choose Health and requested that me and Brad are called to account for what we said within the articles, and so we're grilled in this episode by the Physio Matters podcast's very own Rob Tyre. We hope that this podcast can be enjoyed before or after reading our articles, but it's certainly best served alongside them. And so for a special price of £18, listeners can download both articles and the podcast at www.co-kinetic.com/category/ITBS. Finally, if you're quick to the airwaves and are listening to this in the first 48 hours post-launch, you can get an extra 20% off with the discount code ITBS Matters 48HRS. That's ITBS Matters 48HRS, and that's all in capitals. And so to session 27 with Rob Tyre taking me out of my comfort zone and of course interviewing the real expert, Brad Neal, whose first Physio Matters broadcast, which was a response to Greg Lehman's podcast, can be found on our YouTube channel. I'll see you at the other side.
Welcome to Jack and Brad for the first time sitting on the other end of the desk for the recording of session 27 and for a return visit with Brad following his episode with Jack on 16.5. Thanks for inviting us down to your place of work, Brad. I'd just like to start off by, if the people out there haven't already heard your previous episode, to tell them a little bit about yourself and what you do here.
So my name is Brad. I'm a physiotherapist and Director of Research at Pure Sports Medicine in London, and then also a PhD candidate at Queen Mary, University of London, in the Centre of Sport and Exercise Medicine, which is where we're sitting today.
Fantastic. And for those of you who are listening for the first time and don't know who any of us are, Jack, could you just give us a little bit of background about yourself?
Yeah, I'm Jack Chu, and I feel like I might have created a monster in Rob Tyre who's going to interview me, so the tides have turned. I'm a physiotherapist. I work as clinical lead and co-founder of Choose Health. Also work at IPOPS, NHS service in Staffordshire and Stoke-on-Trent as an extended scope practitioner part-time, and usually the chief interviewer for the Physio Matters podcast. But with SportX journals, now Co-kinetic, we've partnered with them to produce some audio material, and part of that was to discuss the articles that myself and Brad brought out just a couple of months ago now, and to be grilled and held to account for what we said.
Yeah, and if you haven't already got on to the links, we can always post up links to how you can get yourself onto Co-kinetic and access these two articles. I've had a good thumb through them several times, and they are very, very, very good articles, and they give you a good list of resources at the back to follow up and expand your reasoning and knowledge base on.
I don't know if I'm ever going to want to read it again after this, but we'll see.
So I suppose it's only polite to start with the proper guest, and we'll start with Brad, if that's all right. You can just keep your trap shut for a little bit.
For a change.
We spoke a little bit, I suppose spoke's the wrong word, a few messages back and forth a little bit about the biomechanics section of some of these papers. And for me, as a non-biomechanist, something that I've covered briefly at university, I just wanted to try and clear some things up that I thought were maybe contradictory in some of the articles out there. Not necessarily with yours, but with just the references that are deemed high level, like Fairclough and Norrin. So the first thing to sort of bring up was that Fairclough discusses tibial internal rotation, Brad, as a large component of ITB compression. And then Noren suggests that actually peak compression occurs at peak hip adduction. Now for me, and obviously I'm doing this with my hands a little bit, which is not great for audio, but peak hip adduction would suggest you either have to run on the outer border of your foot to get tibial internal rotation, and if you don't do that, then aren't you getting tibial external rotation with peak hip adduction?
One of the frustrations with all research, but certainly it's very prevalent in work based around biomechanics, is there's little consistency of terminology, and that makes it confusing for scientists reading and extrapolating that work, having done some meta-analysis work around various different papers, but also for non-scientists and clinicians reading. If you want to take this work and put it into practice, the somewhat confusing terminology definitely makes life harder. So the easiest way to break it down in your minds for me, and this is essentially how the various 3D movement systems work when you look at the way someone moves using a 3D kinematic system. So we use a system called CodaMotion, a piece of software called Odin. Some of the other ones out there on the market are Vicon is the big sort of name you'll hear. But they essentially break the body down into segments, and your global coordinates often come from your pelvis. So when we talk about hip adduction, we're talking about the thigh segment, which is the femur, moving relative to the global coordinate system, which comes from the pelvis. And then when we talk about tibia, we're talking about what we term the shank segment, moving relative to the femur segment or the thigh segment sitting up above. So people should be more consistent with the way that they describe things, and you can also describe adduction of the or abduction of the entire limb based around the tibia or around the knee as well as the hip, so it does get quite confusing. But tibial internal rotation is generally thought to be coupled with hip adduction, but theories of coupling are sort of often debated amongst the literature, and if you read our systematic review in the Journal of Foot and Ankle Research, which looks an awful lot about rear foot movement, we describe some of the sort of classical sort of coupling mechanism of rear foot eversion, tibial internal rotation, hip adduction, and a lot of that is classical theory that doesn't have a significant amount of weight behind it. So the best thing to do is try and separate the variables and look at them in isolation, as opposed to thinking, well, if that one's looking at adduction and that one's looking at tibial rotation, how do the two come together? It's quite difficult to do that.
So then, to make it that little bit easier, we've got the benefit of your experience as a clinician as well as a researcher. If you've got somebody in front of you, Brad, what are you looking for?
For me, I mean, and I've said this previously, and it's certainly something we say when we look at our run retraining courses, is generally speaking, if we're going to try and affect one plane, we'd focus on sagittal plane for retraining. And when it comes to an assessment, I think it's definitely fair to say that sagittal plane and frontal or coronal plane, as it's sometimes described, are easier to see with 2D motion. And we also know that the transverse plane, so anything rotation based, is also the least reliable when we look at 3D kinematics. So if you look at the work that's been published looking at how much does 2D kinematic assessment correlate with 3D kinematic assessment, we know that hip adduction, frontal plane variable, is the most reliable. So clinically for me, if I'm using 2D motion analysis or just live motion analysis with my eyes, I'll always look at the frontal plane first, if that's what we're thinking about in this case.
Great. That's great. Thanks, Brad. Just on that, we talked about Fairclough's article suggesting ITB syndrome's a compressive condition, and I'll open this up to you as well, Jack. And just be interesting to know where you think we're heading in terms of classifying the reasons for ITB syndrome. Do you think it is a compressive condition? Do you think it's predominantly inflammatory, that some of the research suggesting the fat pad and the bursa being a big driver to this? So what are your gut feelings about what you've read and what you've seen?
I think it's difficult with ITB syndrome, and one of the reasons is, and I happily say this to my patients, is it's a bit of a champagne problem. If you don't try and run half marathon or beyond, you generally don't experience it. It's rare to see a sedentary person come in complaining of symptoms that eventually are diagnosed as ITB syndrome. So the amount of work out there on ITB syndrome, if you compare it to patellofemoral pain as an example, they're chalk and cheese. You know, the systematic review we published recently in Gait and Posture, which looks at running and patellofemoral pain, there's 27 studies. If you have a look at this narrative review in Co-kinetic that Jack and I worked on together, there's very few studies that look at the biomechanics of runners with ITB syndrome or prospectively. So it's a difficult one to answer, because every answer we can give is going to be more grounded in the sort of experience pillar of evidence-based medicine as opposed to the evidence. But for me, if you think about biological plausibility, which is the term I use for an emerging area or a developing idea, does it make plausible sense that variable will be affected by that variable? For me, frontal plane compression, I think it's more appropriate a term than friction, but I wouldn't necessarily say that's a term I would use with patients, in terms of is it friction, is it compression. I think the important bit for patients is often an inflammatory pathology, and that's often the primary driver of the pain that the patient's experiencing. So that's the way we go about dealing with it frontline, as opposed to worrying about is it friction, is it compression.
What about yourself, Jack?
Yeah, I think there's a couple of things that we both sort of skirted around in the pieces, and I think the jury is still a little out on a couple of things really. The friction versus compression, and I think it'd be unhelpful for us to say that that's a dead in the friction or movement of the RTB is dead in the water. It's still something that could swing again, and we never know what might emerge. Also, whether it's a bursal irritation or a fat pad compression, that's still again something that further cadaveric research or any further work that might be done in vivo might change that. But generally speaking, I think at the moment we can fairly comfortably say that something within the lateral recess, which is a term I think both of us have used in our papers, is being annoyed, and that is annoyingly vague, but that is somewhat agreed upon compared to it, say, being the ITB itself that's become pathological, as it's often been, or more recently been suggested, that the distal ITB is somewhat almost tendon-like in its structure. The idea, I'm not aware of any work that's come out, and Brad might correct me, that suggests that the ITB itself has become tendinopathic, and it seems to be more an irritation of the recess structures.
With what you said though, on it being an extension of, or almost likened to a tendon, and the emerging research that's coming out certainly by Ebony Rio's group on tendon sensitivity or nervous system sensitivity within the tendon, do you think that's somewhere that we could be led and therefore not necessarily matter too much in terms of a mechanism-based classification of inflammatory, compression, friction?
Well, this is kind of why I think it's interesting that those of us that really care and those of us that are quite geeky about these things, we do want to discuss the minutiae of, is it compression, is it friction, what is it that's being said compressed or being rubbed on. However, you're right in that pragmatically it probably doesn't matter too much, but it sort of does when it comes to some of the things that we talk about. I'm sure the questions will lead us to, and the case studies, that when we start to intervene, particularly chemically or pharmaceutically, that's where it starts to matter. It'd be, if it was more tendinopathic and it was there was emerging research to suggest that it's degenerative and that we'll say we're having an influx of ITB ruptures distally, that'd somewhat change management. So I think it's worth paying some attention to. However, probably at this stage, I think we can muse over it a little bit, and then we need to probably crack on. I think clinically, why that's happening is very difficult to say. Causation in any form of MSK generally, I think, is tricky, and a lack of prospective work, particularly in an area of dearth that this is. The reason that this came about was because there's an area, it's not a well-researched area, it's not something that we can draw really specific pathway-based guidelines from. And so instead, a narrative review, a case study, start to offer a pragmatic solution to these problems that we see in a sporty population.
And hopefully generate questions that can then be answered in research.
As is science, yeah, and that's a really useful thing, I think, that can sometimes just fuel that a little bit. Any questions that come from listeners of this, readers of the work, and other questions that I certainly had following it, when I read it back and realise, even just in time passing, what might have changed. I think that's the sort of thing that can fuel research from a clinical level.
Just to rein it back in to prevent Jack from taking over and becoming the interviewer again, to get a similar sort of soundbite from you that we got from Brad regarding your little gems that you look for whenever somebody comes into the clinic with lateral knee pain. What's sort of the first go-to assessment or subjective question strategies you have?
Okay, yeah, I think with, I'd be surprised, again, super anecdotally, which seems a dirty word in some ways, but I'd be surprised. I don't feel like I see someone who's not changed their running load volume, or that hasn't reintroduced something new. I'd be surprised to not. I can't even think of a case in which there is a situation where someone's not brought something to the fore more recently, be training for a new event.
No insidious onsets of ITBs coming into your clinic. It's more there's a pattern recognition.
I still would sometimes categorise them as insidious. I don't think that certainly if you think about insidious and traumatic, it's a weird spectrum. But generally speaking, I'm not saying it's a real sudden flare, but usually there's it starts to grumble around something new, and sometimes it can even be a change in footwear, but it's usually coupled with something.
Would you often see it though that with patients coming in, they often have an idea why they've got it, as opposed to other insidious conditions?
And they can then bring that forward.
Yeah.
And so, again, super reluctant to attribute causation to even those things I've just described. They're not why they didn't get away with a change in load, why they didn't get away with having a new change in footwear. I mean, usually they're coupled. I often find people have bought a new pair of shoes for a reason, and so it's usually they want to blame something. I mean, I don't get people coming in with ITB syndrome blaming their bed, which you often do with spinal conditions or neck pain. So equally, I wouldn't demonise a pillow if someone came in with a grumbly neck when they changed pillows. I wouldn't do the same thing. But it's a feature that can sometimes start to be a lookout. And particularly subjectively, I'd then scrutinise that to try and work out what might have changed over the course of time, and also what might be going on. How this pain is behaving is usually a big one for me. Just the typical stuff, your irritability, sensitivity. If you're struggling to run, is that on the first step? It seldom is, in my opinion, with ITB syndrome. It's not that the immediacy of weight bearing is sore. Equally, if they say they went on a long walk, they don't typically, they're fine with that, or they can often pursue swimming. You can sometimes get it with cycling, but generally speaking, they're usually okay with fairly low level cycling, for example. So these are all clues for me that might help with differential diagnoses. But around that lateral recess area, I can't say that I find it a very difficult differential diagnosis sort of location of symptoms.
And there were several tests that you put in your review, a barrage of tests almost, despite what you're saying in terms of there not really being much else around there that could be manifesting this lateral knee pain. And again, I don't want to sort of scrutinise the paper in the sense that you don't normally do those tests, but just out of interest, do you throw those barrage of tests at people, or?
No, I think that's definitely a fair point, and I think you should scrutinise the paper in that sense. I think the context in which it was written initially, I think is worth maybe mentioning to the listeners that might hopefully go and have a little read of it, is that it was initially written quite a while back now as part of a case study that I did for my injection module of an MSc module. And in doing so, I think that although I would stand by when I read through and look at how how the patient was treated and managed, I think the explanation and extrapolation of the assessment process, especially I had luxury of an hour's assessment back then as well, which meant that I suppose in terms of elaborating the differential diagnosis, I can't say it's completely atypical, but I think when I look back, things like Noble's test, Wren's test, I seldom use, and I don't feel like they necessarily offered too much in this circumstance. But as a means of exclusion, things like, from what I recall, I did some meniscal testing. It would be highly irregular from the subjective story that would be, likely.
And obviously with case studies you're looking to demonstrate to the reader that you've considered alternative conditions. And I suppose that's why it's in there.
It is. I think though, just to scrutinise myself on it a little heavier, is that shouldn't necessarily mean that patient is going to suffer from me taking up precious time just for the sake of entertaining a project. So when I look back over that, and I think things like Renz and Noble's tests are tests in which you happen to be having a look at the limb almost, and you're integrating it really easily. There's no time wasted. Checking when I'm palpating to check someone's joint line is it's just almost a matter of habit. From what I recall, I did a various ligament stress test, for example. It's something that, had it have been something that I'd set up and it would waste a lot of time, I don't think I'd get away with that morally or ethically, because I'd just be using this as a guinea pig. Whereas really when I look back over it, I think I smirk at thinking I probably wouldn't do that on every occasion, but also I don't think I wasted time with much of a performance.
Just one further question on that, Jack. And I know you've certainly mentioned that Mrs. X in this paper had a previous injection from another clinician on a separate episode of ITB problems and came in and was keen to explore that as a modality. And to be maybe a bit harsh, would you have given her request the same credence if she came in saying she'd had benefit from crystal healing or acupuncture or massage? Would you have done that with her, or was it just because you are an injecting clinician and the risks are relatively low?
Yeah, I think, well, there's 2 or 3 parts to that, isn't there? But I'll go for the last one first, in that I absolutely would stand by the fact that it wasn't that I was stood there brandishing a needle and keen to do it at that moment in time. This is one of only 2 or 3 ITB injections I think I've ever done, and it does coincide time-wise with when I was doing the module. However, I do feel there is justification in the realm of biological plausibility, some granted low-level evidence, but no less evidence for it than other modalities in that area, but certainly more evidence for it than, say, some of the very out there things that she could well have requested. And in some ways, I can't recall with this patient, but sometimes people do, particularly ITB syndrome. There can be some quite obscure things that people are doing. They can be really torturing themselves over a foam roller for several months or years even, and think that is their perception of what they need to do, and they need to do it harder, and they're coming in laced with bruises. And so, no, I don't find myself pandering to patients much. But in this circumstance, the desire for an injection was completely fair and rational, considering that 8 years ago there'd been a real benefit from it. There's also, would I typically, if there wasn't that desire there, would it have been my first go-to thing? Because it's very unusual for me to inject and then rehab as a matter of first course. So this, I think we injected on the first assessment, very rare. However, sometimes we've got to be a little bit more realistic and pragmatic on these things, and someone was going to inject her. And I don't know how much I agree with the fact that that's the case in society right now, but she was very keen for that. It was very irritable, very sensitive at the time, struggling to break into anything, starting to really aggravate things with basic assessment, and therefore, had I not have done that, and based on the fact that I could do it with a real good plan in place, I do feel that she'd have gone elsewhere. And I don't necessarily mean I just mean that the GP would have pulled the plunger. I don't necessarily mean she'd have gone to a competitor. I don't necessarily mean she'd have then gone elsewhere in a sense that it would have cost business or anything like that. There wouldn't necessarily have had to be a breakdown in relationship. However, it was in a situation where she was being rational, being reasonable. It was indicated in several ways, certain biological plausibility on the fact that it would make sense for us to try and settle that down. And then she was incredibly engaged, because it wasn't just the injection had been the magic bullet before. The injection had facilitated a process last time, and so to encourage her that was not going to be the magic bullet this time, I felt like there were enough boxes ticked there. But admittedly, typically I go a few weeks to try and settle it down first without being invasive.
That's fair enough.
Does that make
Yeah,
sense?
yeah, definitely. I
That's
didn't want it to
another
sound like
idea.
a harsh question
No,
at all, but
I think it's a totally fair. It's the first question I'd asked myself.
Yeah.
I was reading that. It was someone else.
I mean, it all comes down to what should, I hope, be the frontline intervention for any pathology that we see when we assess a patient, which is appropriate advice and education. And if you give people the appropriate education before you proceed to an injection, you should then reduce the risk of secondary complications of people thinking, fantastic, this feels magic, off we go. And don't get me wrong, there will still be patients that do that, and I made my peace with that a long time ago as a clinician. If a patient does not buy into my approach, or if I lose a patient to follow up because they didn't like what I've suggested and they've gone down the road to see someone else who's more likely to do potentially less evidence-based things, I'm not the one with ITB syndrome or low back pain or
you do
whatever
get
else
people
I'm
who
treating.
tend to therapist hop until they hear the thing they want to hear from someone. And I just wonder whether injection therapy, maybe certainly on Twitter, doesn't seem to take that much of a bashing compared to things like manual therapy and acupuncture. And I just wondered, how is it any different from another passive mechanism which could generate over-reliance?
Yeah, I think it probably should be scrutinised more. I think certainly where I work currently within the NHS, a couple of days a week, under the likes of Stephen O'Rourke, Paula Deacon, Richard Lee, forever we're scrutinising these things and trying to work out how to be less invasive, constant decrease in amount of times we inject anywhere in the body. And so I think it probably does deserve more of a beating than it maybe gets compared to things. But I also think people are a bit evangelical about how they abuse things like needling, things like taping, things like manual therapy, and we've talked about that in several other episodes. So I'd probably meet it somewhere in the middle. Yeah, probably it should get more scrutiny, but equally I think the other things shouldn't be degraded to the extent that they are. Some of them are interesting lines of inquiry in young parts of science and they get beaten to death. So I'd probably meet them somewhere in the middle.
And it makes me go back to the whole scratching the mosquito bite analogy. But then I sometimes wonder, are we punishing the person for being bitten in the first place by not giving them something to help them with their pain? Mm-hmm. And it's a difficult one to
You've got to think
walk.
about the cost benefit analysis and the costs. I think Brad covered that nicely just then with regards to what are the medically deleterious, potential deleterious effects, but also we shouldn't underestimate what you're saying with regards to the psychosocial implications of doing something like that. However, we've got to allow ourselves to somehow gain insight into that person's story and the narrative they've shared with you. And I think if we were to neglect that, then potentially I think it would be unhelpful. But we're fortunate enough to recognise that there is a difference in someone's story, and the likelihood of it becoming a, shall we say, nocivic event of sorts, or it be detrimental, are going to be for reasons much more than just the thing that's been injected or that application and the way that that's described. And if we're going to do these things, we need to box clever sometimes.
That's a fair point. Brad, you put an interesting section in your article with regards to surgery. I looked at the paper that there was reference in there. I believe it was by Matthews, and this researcher was suggesting or reporting 100% success rate for return to play and an 89% success rate subjectively from a patient's point of view. And if that's the case, why shouldn't we bang everybody off to surgery?
They're brave numbers, and I will completely hold my hands up to picking the low-hanging fruit in some of those sections, in that surgical interventions for a variety of things certainly is not my area of expertise. Easy fruit to pick in this case, because when you do an appropriate search, and hopefully everyone will agree I'm reasonably capable to do a systematic search, there's not much out there. So the question for surgical referral is a good one, and so there is a surgeon I work with, not frequently, because ITB syndrome isn't as prevalent as some people will suggest, but there's an orthopaedic surgeon based out in Wimbledon called Jonathan Bell, who's developed I don't know if he developed it, I don't want to put my head on the chopping block and have him accused of stealing someone else's idea, but Jonathan and I have shared a handful of patients after a minimally invasive arthroscopic release of the ITB, and they've all done very, very well. They have all been recalcitrant cases that have failed a variety of conservative management, and in Jonathan's hands and in my hands afterwards, they've done well. So,
and what do you think the perceived mechanism of that? Because I struggle as a non-surgeon to then not question the enforced rest that comes after surgery and the graded rehabilitation that is often ensues after surgery. And if we had maybe gone down that route initially, would we have faced surgery? And this is a philosophical question rather than
they often have them, haven't they?
Yeah, and I think that's a fair point. I mean, Jonathan's procedure is a minimally invasive release where, not dissimilar to Håkan Alfredsson's tendon procedure, he essentially debrides the ITB from the fat, the mechanism being targeted being that of a reduction in compression. So there's definitely that argument as to, is it an element of enforced rest and graded exposure, but certainly some of these cases that we've shared together were under my conservative care pre-op and they failed.
And did your management differ? If you can recall, did you do anything differently post-op to pre-op?
Not necessarily, no. I think the case that really sticks in my mind was an elite level GB triathlete who failed conservative management, consisting of the typical things we would look to achieve, which was an initial period of unloading and failure to return to run, followed by an injection and rehabilitation process and failed return to run. My good colleague James Dunn was involved from a run retraining perspective as well, not just myself as a scientist and clinician that dabbles in running, as opposed to someone that is actually invested in the performance side of running. And unfortunately, whatever we threw at this triathlete, including the kitchen sink from an evidence-based perspective, did not deal with symptoms, and he's currently performing at a very high level and returned to elite triathlon approximately 5 months post-procedure. So to sort of go back to your original question, is there sometimes scope for immediate referral to surgery? I think it's a good one, and we're terrible in physiotherapy for becoming very baby and bathwater. So if we take the knee arthroscopy and meniscal tear debate at the moment, or even ACL reconstruction, there's a real drive for ACL injuries to be managed conservatively, which, if you look at the data, undoubtedly there's an argument for that, but that doesn't mean that there aren't still some people out there for whom an ACL reconstruction is a really good operation.
Oh, for sure.
The same goes for a meniscal tear. So I think there probably are patients out there with ITB syndrome that would undoubtedly benefit from early surgical referral. The difficulty we have at the moment is we can't pick them, and that's what's challenging.
It always makes me laugh with I think the grumpy physio on Twitter when he says there's a physio out there crying when every time a patient goes for a knee arthroscopy, there's a physio out there crying into his yeah.
I think that's definitely true. I think there's probably more than one crying at any one time. I think though, while we can't find those people that are indicated early, I think that we go back to what the patient wants, and unlike injections to some extent, although you do get people that are very reluctant and quite rightly reluctant to have an injection, there's a lot of people that would want to entertain a sensible process of conservative care prior to surgery. And I think that it'd be intriguing to hear from Jonathan Bell, apart from in these particularly elite circumstances, I imagine that he'd want some imaging clarification as well, and there's a number of features that might mean that the person gets the scalpel before they get some gait retraining, rehab, etc. But from a patient point of view, the ones that I seem to see, they'll give you a few months to work with them. I think that more often than not, and they give you a biologically sensible period of time and a process of true engagement. Unlike other body parts, as we're saying, these are a group of people that recognise that this is a cumulative load issue. They're not people that necessarily attribute it to. They're easy to persuade that it's less structural than others. If it was because it's been insidious, they don't feel necessarily as broken as people that might have had a more traumatic or elsewhere. There's a sharp pain. Shoulders are a classic where it might be insidious onset, but there's something that feels like every time they move, there's something there. Whereas the ITB, they can usually understand that it's something less than just wholly structural. And
you wonder whether that's because they come in often knowing why they've got it. They can rationalise that it's less likely something damaged, like a mechanic.
Yeah, and in doing so, I think, therefore, although there might be a small fraction that might need escalating quicker, I think we'd be able to pick that up fairly swiftly as to the sort of person that is, we would recognise are not responding well to conservative management and building them back up. And especially with Brad's example, he's building it up to a very high level, high usage, high mileage sort of customer. And in those circumstances, sometimes that's the irritating one, where you get someone to 80%. And they are in an age in which they were progressing either recreationally or otherwise, and they get to 80%, and they're then surgically indicated. That's really tricky.
Depends on what they want to get back to, I suppose. And this elite athlete obviously is one of the 5th percentiles. It's not going to be there for every IT band patient coming in who's going to fail everything you threw, including the kitchen sink at them. Yeah, so I suppose going back to your point before, you've got to be pragmatic about these things.
Yeah, and it's important to remember that the absence of evidence is not the absence of effect, and I'm sure there are physiotherapists out there, and I'll happily bash the physiotherapy profession if I need to, because it's what I do and it's what I love, but I'm sure there will be physiotherapists out there that would see a patient go straight to a surgeon and have a surgical procedure, and they would absolutely, abhor that surgeon for proceeding. But ultimately, if you look at the evidence base we have in front of us, they're not doing anything wrong. And often, particularly as physiotherapists, I think we're better at evidence-based medicine than some, certainly, but we're also very baby and bathwater in our approach in the way that we latch onto things. So I'll use gait retraining as an example, which is my PhD topic and my academic area. At the moment, it went live in BJSM yesterday. We've just published a large mixed method study on gait retraining, systematic search revealing 54 papers includable. Only 6 of them contain people with symptoms. And if we look at patellofemoral pain, which is my area, there's only 2 case series of an N equals 20 to show that gait retraining changes pain and improves function. But out there across the board, it's becoming widely accepted as a frontline intervention. And without switching my bias off, that really pleases me, because I'm researching it, I'm adding to that evidence base, I use it in clinic, I teach postgraduate courses on it, but I'm always clear to stress an element of control. And you mentioned Emily Rio's work earlier. I'm going to put my head on a chopping block a little bit. I know I've had this discussion with certain people. Emily's a wonderful scientist and she's building a fantastic body of work, but as far as her TNT training goes, it's all based on an N of 6. Can you imagine a surgical paper or a needling paper or a manual therapy paper that showed something positive in an N of 6? It would be our sample size is too small, it's underpowered. But because we like exercise, and because tendinopathy is sexy, and because the nervous system and pain mechanisms are sexy, we all put these blinkers on and think, oh, look at that, we absolutely must do this. And at the moment, we just can't say it. And it works both ways. We can only be so positive about something in an area of dearth, and by the by, we can only be so negative about it as well.
I'd agree with that, and the N equals 6 has been a criticism that's been thrown around on social media quite a bit as well. What I would say is that maybe what's good about it, even the discussion and the critique or the criticism, depending on which way you come at it from, if anything, it's gonna get people talking, and it's gonna get people having a go at it, and then we're gonna start to build an area where we've got more bodies to sort of give this a prospective trial. With larger numbers.
They're building work, for sure. They're building a body of work behind it, so that's certainly not a concern.
We do lack patience sometimes, though. I think that's the nature of it, and I can be guilty of it as well. Sometimes we've talked on many episodes of the podcast about the time scales required for evidence to integrate, and sometimes in an age in which we've got more access, does mean that we make naturally more mistakes jumping the gun and having to change things. And I think that people just need to just hold fire, me included, in hanging our hats on certain things, certain techniques, certain styles, because you're attributing an awful lot on it to have to go back. It would be a poor dude to have to ring all your patients up about 6 months later and say, how are you getting on? Because I've changed my mind a little bit on how I manage that case. That's just the nature of progress, nature of science, and it is a young profession in that sense in musculoskeletal health.
Yeah, like Roger Carey's video on the evidence-based practice practitioner.
Exactly.
It was always a good one. Makes me self-reflect quite a lot.
Yeah, and we can all be guilty of that, but equally we are all it's the only people that put themselves comfortably in front of these microphones are the ones that are certainly on the evidence side of the fence, rather than us saying, well, it's all right, let's allow for cowboys and mavericks to rule the roost and not be held to account. You know, we are recognising that we need to be evidence informed, evidence based, but also the admission that we're not there yet, we're a long way from it.
I just want to bring it back to a few more points that you raised, Brad, with regards to some of the body of work that you've found. Obviously, I haven't had the opportunity to read the BGSM one that went live today, but the other work that you've mentioned would include work by Rich Willey, who's done a lot for running re-education, gait re-education. The one that you quoted on in your paper was an interesting one for me, because they were talking about asymptomatic populations having normal and abnormal hip adduction values, but there wasn't really, and again, I don't want to come across like I'm scrutinising Rich's work, because I've got a lot of respect for the work that he's done, but I just found that there wasn't any mention in there in terms of anatomical variances such as retroversion, anteroversion, which is going to impact on in a knee position or relative hip abduction position. And maybe fairly or unfairly, I'd maybe like to throw a quote that Ian Griffiths, one of your colleagues, gave on our last session of the whole elevator analogy for pronation. And we don't have a ground floor for pronation, so how can we say someone overpronates or underpronates? And could we be being guilty of that with hip adduction?
Quite possibly. I mean, I'll declare a conflict of interest. Rich and I are good buddies, and we collaborate on lots of things. But in terms of saying normal or abnormal, that all comes from the comparison of the retrospective work that's been completed. And if you look at the way that it was determined in Brian Noren's initial gait retraining paper, was to include people that had a hip adduction, a peak hip adduction of 3 standard deviations above the mean within a prospective cohort. So the potential negative of the initial paper that Brian wrote was that we're looking to see if gait retraining can change hip adduction in people that have excessive hip adduction. And hopefully the story that comes out of my gait and posture systematic review is that there does seem to be a story behind hip adduction in patellofemoral pain. Based on one prospective study, we know that an increase in peak hip adduction is a risk factor. In a plethora of cross-sectional retrospective studies, we know that people with patellofemoral pain have greater peak hip adduction than those without. And then based on the gait retraining work, we also know that if we reverse that hip adduction by cueing, we change pain and we change symptoms, function. And that's as close as we're ever going to get to the ivory tower story of research around causation. If you want to say prospective work does not allow for causation, you need to manipulate the variable and see what changes. Well, we've got that. Admittedly, it's in a small number of subjects, because the types of studies that are done on causation in heart disease and diabetes, you're dealing with millions of people that have it. Patellofemoral pain is prevalent, but musculoskeletal injury is never going to be as prevalent as metabolic injury, certainly not in our lifetime, I wouldn't have thought. So you can only look so far, and the argument I make in that systematic review is that, and I know I said this in my previous episode with Jack, but I will repeat it, in that you have to look for a supporting case. And if we know that an increase in a variable is potentially causative in a pathology, and that variable is still the same when people have pain, that retrospective work backs up the prospective work. If we see a variable that isn't different prospectively, but then does change when people have pain, that's potentially an adaptation. We know that the body will adapt to pain, whether it's central nervous system or otherwise. So you've got to look to see the story that the prospective and the retrospective work tells.
Can I ask a question based on that then, Brad, just to clarify? If we were to say go to the other side, and granted I only read your systematic review this morning on the train, I haven't had a chance to sort of get my teeth into it. As you said on Twitter, it'll take you a few days to get through this bad boy, because it's got quite a lot of references.
Huge
so it's a great piece of work. In your systematic review, what we sort of concluded with in the results was that gait re-education could improve pain pretty quickly and improve function pretty quickly, and I think there was moderate evidence to support that. But that doesn't necessarily, and correct me if I'm wrong, it doesn't necessarily go further forward then to say, well, should we remain running in that fashion when we know people who run in the old fashion can run pain-free? So when you modify someone's gait, do you use that as an analgesic to then let them go back to normal running, or do you ask them to maintain this new gold standard for them running style?
Definitely the former, if you look at it in overall terms. If we're using, so the feasibility trial I'm close to finishing at the moment is looking at cadence retraining, and consistent with Brian's work and Rich's work, we're using the same faded feedback design, which is attempting to achieve some skill acquisition so that they will maintain their new biomechanics.
And the cadence work being higher than
an increase in cadence.
5 to 10%
yes,
cadence increase.
7.5, but as far as is that essential for them to maintain that in order to stay pain-free, I haven't got an answer for you because we don't know. And no,
you could chase your tail, I suppose, because if they develop the symptoms and they've maintained that cadence, do they then get pain relief by increasing their cadence further by another 5 to 10%? And on the cadence work, because I'm quite interested in that, and I have seen that in clinic, it improves symptoms dramatically, straight away. The increased cadence would, for me, and correct me if I'm wrong here, reduce time under tension of those structures per step.
Because reduces contact time.
Yeah. So are we effectively improving someone's gait, or are we just reducing the stimulus? We're having a greater total amount of load. I believe if you run for 20 minutes with a higher cadence, you get greater total load.
Not if you look at, as an example, John Wilson and Rich Willey's work in clinical biomechanics looking at patellofemoral joint stress, cadence retraining was shown to reduce stress per step and also stress per mile.
Okay.
But when I run through this with intelligent patients, and I always joke that I presume patients are stupid unless they show me otherwise, I have had intelligent patients that would say, well, if I take more steps in a given period, will that not increase the total load because we're increasing the amount, albeit in a smaller fashion?
You'd think so, with cumulative loading, and I'm pretty sure I've read an article, and I think it may have been in foot and ankle area, that increased cadence does increase total load, but reduces immediate load.
It will increase load at the ankle, so it's important to remember force is invisible, and Ian talks about, when Ian teaches his mechanics course, which is fantastic, he talks about being able to see the forces, and obviously we can't see forces, but it's trying to interpret them. And it's
getting very Star Warsy at the minute. I'm desperate not to jump in with that.
Not a Star Wars fan, so we'll hold that there. But it's important to remember that you can't make force disappear. You can only move it around. So cadence retraining, black and white terms, reduce load at the knee, increase load at the ankle.
Yeah.
So you've got to determine if the patient in front of you has tissue or nervous system capacities that will allow them to deal with you moving that load from place A to place B. So it's certainly not a panacea, and cadence retraining is only appropriate for those that already run with a low baseline cadence. And it's another area where people almost come in thinking they've got the answers. So people will come in and say, I know I heel strike, or I know I overstride.
Yeah.
But they haven't got the understanding of what those things mean. And the mainstream media, Runners World, and probably some clinicians and coaches also don't have that interpretation. So heel strike being a really obvious example, it's not how you land on your foot, it's where you land on your foot. And if someone is not running with a stride length that is excessive for their given pace, if they're landing on a foot that's coming underneath a flexing knee, unless they have a handful of key pathologies, posterior compartment syndrome or anterior compartment syndrome if we're thinking heel strike, or osteochondral defect of the talar dome, something along those lines, I don't really mind what their foot and ankle is doing because it's designed to transfer load from the ground up through the limb.
Could we be guilty of then shifting the load to somewhere else that may potentially develop an issue as a result of increased load beyond what it was tolerating normally? So if the patient's come in with ITB syndrome, we've done gait re-education, their knee pain improves, they go away a happy customer, but they may return in a few months' time with Achilles tendon pain or medial tibial stress syndrome. So my thought process to that would be, and I'm forever chasing my tail, should we be gait re-educating somebody to give them pain relief to continue to run, but then allowing them to get stronger across the whole kinetic chain and maybe allow them to go back to a comfortable position? Because gait re-education is quite difficult, or it is certainly when I've tried to induce it with people.
Yes, it's a good question. I mean, if I do cadence retraining with a patient, then I will automatically give them secondary exercises for glute max, hamstring, calf, if in my assessment I've found those tissues, structures to potentially be incapable of dealing with the new loads I'm going to ask them to tolerate. I'm going to pick on you now. It's interesting that you keep saying stronger, and that's one of my big areas of interest that we're hopefully going to get into a little bit here within our lab, and something I said in Denmark a few weeks ago when my colleague Simon Lack and I were invited out to Aalborg University to do some teaching with Michael Rathleff, is when it comes to exercise, and one of my big issues with exercise as an intervention is we don't know what it does. Getting someone stronger or increasing strength is not necessarily the solution to a problem. And when you look at studies that look at exercise as an intervention, we know they're not very good at A, describing what they're doing, but B, sticking to what they've described they're going to do. So Simon published a systematic review last year which looked at proximal strengthening for patellofemoral pain.
Yeah, and they found that people had a lot higher strength in the hip muscles.
No, not at all. So there are some papers that have shown that potentially an increase in hip strength might be a risk factor for PFP, which muddies the water further. I've got some ideas on it, but it's probably not appropriate for today. But what we found in those 14 studies is that only 3 of them actually delivered the intervention they described. So, as an example, some papers described a strength protocol and they actually delivered a neuromuscular protocol based on the Toigo and Boutelier descriptors of exercise paper. So, if papers aren't doing a very good job of describing the intervention, it kind of comes back to the biomechanics discussion we had at the start and the lack of consistency with nomenclature. But they're also then not actually delivering what they're suggesting they're going to deliver. It becomes very hard for clinicians to actually know what to do. You know, what exercises would you give someone with ITB syndrome? It's a very, very open-ended question. But
that's something I wanted to talk a little bit about as well, but sorry to jump in there.
Well, I think it comes into it. It's like there's so few, if any, papers that will discuss the dosage of said exercise intervention, as well as the particulars of what it might entail.
And we only extrapolate that from the uninjured population papers in strength and conditioning, don't we? We take that dosage.
Which is a frustration of mine, certainly, and I know of many others. But when we talk about biomechanics, in this sense, and with many, I do admit to myself that I called something called the kinetic dilemma, which I've talked about a little bit before, just not on the microphone, and I'd be interested in both of your thoughts on this, is that if we were to talk about the nature of the fact that we understand that it's the cumulative force and the kinetics rather than the act of moving the kinematics that would be, I think Kevin Kirby describes as it's the landing that will kill you, not the fall. If you jump off a building, the idea that it's the reaction that is the act of falling doesn't hurt. But essentially what we're dealing with then is a force that then to translate on a tissue, and that tissue then is taken beyond its cumulative stress or its tolerance at any given time. Hopefully you guys are with me so far.
Zone of optimal stress.
Yeah, so it's gone beyond its envelope of function, and often a number of different ways it's been touted. We then recognise that tissue then becomes somewhat reactive to it, and therefore we know nociception occurs. Now, we then take a bit of a leap from any part of the body now, and if we talk about the ITB specifically now, we've got to then, if we were to then discuss anything either prospectively or afterwards, we've got to recognise that we are taking a bit of a leap to suggest when we're looking at risk factors, we've got to then think, we've got to make the bold claim that in a certain cohort of patients, in this case those that develop ITB syndrome, or in this case an athletic population that develop it, to suggest then that nociception is sufficient to pain in that population, I'm yet to understand that being determined in any study. And the more particular we get with, the more accurate we get with our imaging, the correlation again is increasingly poor. And so I find, to go to your question as to do you return them back to how they want to run, I think running, but as a runner and as someone that works with runners, running is an incredibly liberating human experience in which I find that to use running retraining, use metronomes, use external cueing as a means of rehabbing someone, the fact that the process has educated them, the process has maybe strengthened them, the process has changed some of their mechanics in the short term, I would personally favour returning them back to how they want to engage with their world.
So then would their training or their rehabilitation, to maybe correct some of the language you mentioned from my end, Brad, should we be then giving people resilience exercises to be able to tolerate those sort of forces rather than strengthening exercises strictly?
I mean, as a scientist, I'll hold my hands up and say I can't give you an answer, because until we complete a study where we deliver an intervention, let's say gait retraining for 6 weeks or 12 weeks or however long we do it, until we follow those people up at 6 months and 12 months and repeat their kinematic capture and see if those that went on to develop recurrent symptoms move differently to those that did not develop recurrent symptoms. In terms of returning them to their old mechanics, I can't give you an accurate answer for that at this stage. Clinically, and I say this to patients all the time, I definitely know I see people that walk out of my door the minute I discharge them, and there's no such thing as a discharge in private practice, but when I say to a patient, look, I'm not expecting to see you again unless you have any more problems, but if you do, you know where I am. I know there's patients that go away and forget everything I've told them and don't develop any further symptoms. I also know, Canary Wharf, City of London, type A personalities, there's people that head out pain-free, do everything I told them to do, and they'll still come back with symptoms, and the exact opposite of those two scenarios. So my answer for patients is always, I've given you lots of knowledge, I've given you advice and education, I've shown you exercises, I've shown you how to change the way that you move. It would be sensible if you blend some of that into your typical routine. And that's where, and I'd encourage all sort of young or old physiotherapists who don't have that skill set to broaden their horizons with regards to the strength and conditioning literature and strength and conditioning courses. And my end stage rehab programs would often look like a workout, for want of a better term. So I think that's where it's nice to get people to be compliant long term with the things we've shown them. If you can get it something that almost feels like it's something they're doing for them as opposed to something they need to do in order to stay pain free, they're more likely to do it. Whether they need to do it or not is a wonderful question, and it will be a really nice question to eventually answer. But at the moment, probably as much as we know.
That's great.
If our understanding of MSK pathology at the lower limb or otherwise, biomechanics was seen and regarded as being integral to the large degree, that would essentially still be then structuralism, wouldn't it? Essentially, because we know that the act of movement, if we're saying, is less relevant than the forces it produces, and then this envelope of function, that is essentially just on a microbiological level is still damage equals pain, isn't it?
Probably, yeah.
And so it would, if we got that, which we might well do, as far as I'm aware, there hasn't been a structure equals pain.
We not read Subtle Leopard?
Sorry, in the academic literature, I'm yet to see something that has demonstrated these people have more tissue injury and therefore have more pain. And if we get to that point in a biomechanical sense, I think sometimes we might miss the idea that is then bringing structure back to the party in a big way. And if that is predictive, then it takes a big U-turn on a lot of the pain science literature, and which it may well do. But it would need to do that in order for us to hold biomechanics in high regard. And I don't think we're there yet. And so for me, I use biomechanics as a means of identifying how you can offload certain structures, as a means to, I can't yet comprehend it in terms of a corrective mechanism. It's just that I've influenced change, and that has been
something's
sufficient.
happened. It's been positive.
That has been sufficient. Or
Yeah.
I've made I often use this term, and I don't necessarily even like it that much myself, but I've made nociception less relevant right now. Yes, we're trying to influence nociception, but at the very least, we've gone through a process of education, we've gone through a process of making a plan, we've assured that person and really listened to their worldview on this problem and how they engage with their world generally. And we've then gone about trying to make that nociception less relevant to that problem and that person in that moment in time. And at the moment, that's how I tend, although I wouldn't necessarily need to change that too much if we become more biomechanically driven. The reason that this biomechanic's changing in the patient in this case study, for example, that's the reasoning that leads me there, rather than it being to decrease the deviation from normal in that circumstance, which I understand that's probably where me and Brad found ourselves disagreeing.
I don't think so. I mean, I think you can apply that to any variable. I mean, that's why I'm a big fan of someone's primary driver. That's what I'm looking to identify in my clinical assessment, and their primary driver will be often what I target as my frontline intervention. So more often than not, people that run with patellofemoral pain, especially if they're female, have a primary driver of increased hip adduction. So if I change that and their pain gets better, that sits nicely supported by the published literature. In terms of what they need to do afterwards, as a scientist, I know that has been shown as a risk factor. So in that case, I may give them some advice on potential long-term maintenance. But it's certainly not the be-all and end-all, and that's because risk in musculoskeletal injury, I guess in any pathology, be it MSK or otherwise, but particularly in musculoskeletal pathology, risk is so multifactorial. And I know people look at Brian Noren's study and say, well, how many people in the cohort that did not go on to become injured had a hip adduction reflective of what was found to be the significant increase? And that's good insight. But you can only look at what went on for some of the people, some of the time within that cohort, and there's no doubt that we need a greater breadth of prospective research. But whilst hip adduction may have been the primary driver for a person at one point, that doesn't mean that next time around it will be the primary driver. And you can apply that to any variable if you want to think about some of the variables that are discussed in the pain science literature, like sleep and stress. I know people that sleep 4 hours a night and are stressed to the eyeballs, but they don't develop musculoskeletal pain. Does that mean they won't ever develop musculoskeletal pain and have that as a primary driver? Absolutely not, but it's not something we have to change in everyone. And I think the criticism I would have of people that are dismissive of biomechanics is they think that it's the be-all and end-all, and that we think that it's, I don't want to suggest that there's an us and a them, because there isn't, but you could be forgiven for thinking that because I do research based around biomechanics, that's all I'm interested in, and that I think that people have to make frank changes to things and maintain it in the long term in order to stay better. They absolutely don't. We just don't have the depth of research for me to be black and white within that answer. But if you listen to some people that talk about variables within pain science, they will say it's the be all and end all for everything, and you must change those things. And for some of the people, some of the time, you probably do, but for some, you probably don't. And what you were just saying there, I think, is any variable in terms of I've identified it, I've made a change, I've altered your nociception, you've got better. Do you need to change it in the long term? Probably not, because we can't
the identity of a primary driver is the bit that's tricky, because the only thing that we are really able to attribute it as being that we were correct in identifying as a primary driver is the success of our outcome, isn't it? To some extent. And so, have we just changed enough? And there were 10 different ways in which we could have changed something, and we've decided to pick the biggest fish to fry. And I do agree, and I suspect therefore that we would probably manage people in a similar way, just maybe for different reasons. And it's just that when we identify it as being something that we look for in someone that is running, that isn't then in pain in that snapshot of time, we don't always, I'm sure you do, but not everyone recognises that. Did you run yesterday? How fatigued are you? What time of day is it? All of these features and variables that can then result in relative hip adduction, when we then assess them, we can sometimes see a snapshot of a patient in a moment in time that we don't always necessarily know whether that correlates with every time they run, whether that correlates, although we do have some good material to recognise that there's a difference between treadmill, less difference than we once thought in treadmill and track and things like that, treadmill and road. Do they run on different surfaces? Do they always run in those shoes? There's all these irritating variables which makes me still sort of, I'm not a nihilist to suggest that the biomechanics don't matter, but I think that primary driver is the bit that maybe I don't feel like I've got enough skill to identify.
Would it be dangerous to suggest that the primary driver in this population is going to be running? there's work out there on the whole premise of placebo, and it's a topic that I don't expect to get through in 5 minutes or and kind of get to the bottom of today. But the greater the technological input, the greater the placebo often. So like your ultrasound guided injections, is a treadmill an ultrasound guided injection? Is it a placebo?
I think it would be with a metronome, and I think it would be if we were to use language that suggests that we were trying to deviate someone towards depending on the language we use, if we're trying to optimise your cadence or we're trying to optimise your foot strike.
Or the patient's perception of the therapist expertise.
Yeah.
I'm looking at your running.
There is a performance that starts to occur, and that's where I think that sometimes placebo and therefore its ugly cousin nocebo can start to rear its head, and there becomes a flamboyance to that sometimes, not just for gadgets and gizmos, but for the specificity of the intervention. Whereas I really try and err towards, even when I'm being particular, I'm often cloaking it as if it's not.
But there's some people who will love that and get on with it, and there's some people who just won't, and they'll have to go away.
And this lady in this case study, to bring it back, she would never let me get away with being as vague as I sometimes like to be, and so I would step that up, and I was more particular. I was more particular about the way that she graded her running because she wanted that. She was a lawyer. They have laws.
A question that was thrown up on Twitter by Mark Reed. What do you look for in terms of your monitoring? So if you had pushed her too hard, what would you have looked out for, and what would have been your threshold for changing your previous advice if that person came back next week and said, actually, I've had a bit of a bad week here?
For me, I do look for symptoms following into the days afterwards. I mean, one of the reasons why this lady got an injection really was because she'd run for 20 minutes, have 2 days worth of symptoms at rest, regardless of what she did. And that's annoying, that's disabling, and very frustrating for her. And I think that's one of the reasons why we took it easy, was because she had some misconceptions about her pain and did attribute it to certain things. And so we worked on a process in which she wasn't dealing well with it, and so we were trying to somewhat avoid it. And whether that's helpful or not is great discussion, but for me, I look for the signs that interfere with the following days or hang around longer than we want them to.
That's good. What about yourself, Brad? Anything
very,
different?
very similar. I can pad that a little bit. I mean, I will, when I'm teaching our masters guys here, I will always use the sort of core skills, hopefully that we would have been taught in undergrad, which is look to the severity, look to the irritability. And I know there are certainly people out there that suggest that a VAS scale is somewhat arbitrary for people in pain and somewhat unnecessary. I don't agree. I think if you accept that pain is a subjective experience and that your score is not comparable to my score, I like patients to score their pain on a 0 to 10 scale. I don't necessarily care whether they say 1 or 12. It just gives me a marker for change. And if someone's pain-free at rest and they get symptoms at a certain point during a run, for me, there's a threshold somewhere, and it's somewhere around 3 or 4. So my normal advice for people will be, when you're running, if your symptoms are getting up to a 3 or 4 and no further, we're probably okay. If they're going above and beyond that, you're probably pushing yourself a little bit too hard.
So using that person's own personal measuring stick.
Absolutely. But more important than that for me is what Jack was describing there, which is the irritability window. If someone runs for 20 minutes or 30 minutes or however long, and when they wake up the next morning they feel ready to go again, for me that irritability window is okay. Whilst I wouldn't necessarily have them running on consecutive days, I'd like them to feel like they could. A bit like when you buy a house, you don't jump in at your maximum offer. Start people gradually, and then if you see that they're capable, you can push them a little bit further.
That's testing the water, isn't it?
Yeah.
And I mean, all these little sayings and things like that, but if you test the water and see how you go, and if the patient's engaged with that as a process, they'll scale it appropriately. But also you swing the odds in their favour. If this lady was sleep deprived and stressed and had some really altered and obscure perceptions of what would happen if it came back, these would influence the time frames in which you'd scale it. Equally, if it was someone who wasn't going to keep to a diary or keep to a plan, we would potentially we'd err on the side of caution in that circumstance and give them the assumption that we're giving them freedom when actually we're trying to just box clever and work on how they are going to engage with that process. It's very, very tricky, particularly after an intervention such as an injection. We've got a process in which we want to make it worthwhile. It tears you, like I said, physio in tears if they're going over to see a surgeon. I think to some extent we've got those circumstances with any intervention now. This idea that we don't want to do anything passive to someone means that people are wanting to justify it and to qualify it and to make sure it facilitates something. And in doing so, we want to maximise the chances of it being successful or facilitating success. And I've got to admit, I've got to summarise in the fact that as far as I'm aware, this lady, well, I know she did well up to, she got completely right, achieved her goals, particularly in the short and medium term. Whether she's still doing all right, whether she's banging on a GP's door begging for injections every other week, I don't know.
Not to see that bloody Jack Chew again.
Potentially, yeah, she might be cursing me, she might respond to this podcast, but one of the things about it is that it was a successful outcome. It is a pragmatic account of what went on in a real world situation with a real patient who had real positive outcomes. And
we need more of that, I think, sometimes. Reading research and evidence is great, but it's nice to sometimes take away a reflective piece like that where you can have a look and go, oh, that's how this person's managed in that case.
Co-kinetic would agree, and the work that they're doing to try and bridge a gap between, it's similar to what we're trying to do with Physio Matters, is bridge a gap, discuss the literature, discuss some of the hard texts, and then try and make case for clinicians to work out how to integrate it.
As you say, it's easy on paper, Brad, isn't it? Black and white. If you're dealing in absolutes and binaries, but then you're dealing with that person in front of you. And we have a question which people often sit firmly on one side or the other of the fence, and this is from at Luda Chris Legg, and he was asking, do we see any merit in any of the soft tissue adjunctive treatments?
It's not somewhere I go clinically frontline, and that's purely because hopefully the clinical thoughts we've put on the microphone here in terms of primary drivers and variables to target, I don't think you can affect those variables or those drivers with soft tissue techniques. But is that to say that I'm not open-minded enough to think that there might be some non-specific effects to soft tissue massage from DNIC or something along those lines? Quite possibly. I know you can get DNIC from a variety of different interventions, and it's not to say you can only get it from something passive or manual, but there's certainly scope for that. But is it something I would do or encourage my patients with ITB syndrome to do? No. If someone, purely because of the sort of nature of my practice, I tend to see a reasonable amount of second opinion cases. If someone's having soft tissue work and not getting better, then I'll potentially, in a very correct way, suggest that, well, maybe it's time we tried something else. If someone's having soft tissue work and they have a strong belief that it's beneficial, I'd probably let them continue. The only thing I tend to ask people with ITB syndrome to stop is sort of aggressive foam rolling, particularly if they're rolling down towards the insertion of the distal ITB and local to the fat pad. If we think there's a compressive inflammatory component to that, it's probably going to make them worse, but that's the only thing I would ever tell patients or advise patients.
What about yourself? Anything to add on that, Jack, as a throwback to the Sally Lamb podcast when we talked about thinking like a taxpayer?
Yeah, I'd agree with a lot of it, especially the idea that there's frictions and dry needling local to the area, quite aggressively just annoying those structures that we're trying to calm down. And if you were to ask the clinician carrying that out, and particularly if you were to ask the patient that's received those treatments as to what's that trying to achieve, it's usually based on myths and fallacies and ideas that are far beyond normal physiological plausibility. And that's frustrating. And that's where I do often go at this idea of everything's got a place and there being allowance of adjuncts. And that's from someone that put a corticosteroid in on day dot in this circumstance, but I'd fairly strongly justify why I did that over friction in that area, for example. It's the perception that patient then gets from that intervention that is my worry in that circumstance. So then if we were to take that's the really local stuff, if we were to take that beyond and think of foam rolling, stretching, massaging the glutes, I mean, the time is finite. and I'm always saying this, is that if it was a professional athlete in which you were using that as a means of reassuring them and explaining this and uncloaking and caveating it with everything as part of a whole day's worth of treatment, then weirdly I can sort of comprehend that might be part of it. But in a clinic situation that I work in, both in the NHS, in private, in sport, as a consulting second opinion, third opinion, I really struggle, because if it's being prioritised, which it often is, it's based on some pretty out there ideas that get put on the patient, and so there's very, very small minutiae percentages that make me think that that's okay. And if clinicians want to rub people's bums at any moment in time, they might as well rub the contralateral earlobe. You know, it is something that really I start struggling, because it's usually you scratch beneath the surface slightly and say, why are you doing that? You very rarely get an answer that's close to sensible when it comes to what we do understand of both the hard science in terms of interventional studies, plus the general understanding of patient and person well-being, and the difference, the way that belief drives behaviour. And so I think that intervening on most adjunctive levels, I think is in ITB syndrome is certainly fairly deplorable most of the time, because it interferes with the complexity of what we try and do with the evidence base. And the case study, there's no room for it. I was rather busy, doing all the things that we did with that lady. That takes up plenty of your time. It's not easy. Having those conversations, explaining it through. If I'd have tried to shoehorn in some, and she wouldn't have been able to shoehorn in some foam rolling. And if she did, she'd think she was trying to do something she wasn't, and that's not cool.
That's great. I've certainly got a lot of insight from that, and I hope people listening have as well. Is there anything that you'd like to add or finish off with, either of you guys? Anything that's upcoming that you think people might be interested in?
Mine's easy. Listen to Physio Matters, especially ones that aren't this one that's got me all over it. I hope that people do find the papers and we'll make them readily accessible, read them, and even more important than that, read the literature that is referenced in them, and read the body of work that fueled them. And if you feel that you have a different take on the matter, if we've missed something, it's the engagement that we look for. And so finding us on Twitter and Facebook, both through the podcast and through my personal account, would be brilliant. And thanks again for Co-kinetic. We're bringing out increasing audio material with them, readings of their papers to try and get people, not necessarily podcast, but audiobook format journal articles with them.
What about yourself, Brad? Anything coming up?
I'll just echo what Jack said there to start with, really, and just get out and read. And you know, the second you feel like you've got nothing more to learn, you've lost the battle. I'm a big advocate of the fact that the primary source is important, and you know, one of the reasons I spend time sitting down and writing papers and systematic reviews, etc., is because I want people to read them, and completely appreciative of the potential limitations of hard science at times. So we are, as part of our groups, we are working quite hard on translational material, and podcasts is a nice way to do it. So thanks to Physio Matters for inviting me to waffle on for an hour or so. But the work we do with Co-kinetic and In Touch is important, but we're working on building some sort of translational platforms for various different forms of evidence. So if anyone's got any wonderful ideas, make sure you're not shy in putting those ideas forwards, because ultimately I don't believe in camps. I don't think there's a scientist community and a clinician community. I'm a clinical academic. I do hard science and I treat patients. I also I'm not a big fan of camps in physiotherapy, and I think if we all play nice and work together for the collective benefit of the patient, we'll get better outcomes. So just don't be shy with that sort of stuff, really. But if anyone is interested in some of the translational stuff we're doing at the moment, myself and James Dunn at Kinetic Revolution have got a couple of run retraining dates coming up, so have a look at the Kinetic Revolution website for those. And then my colleague Simon Lack and I, Simon's doing his PhD on PFP with me here at Queen Mary, and we've in the process of developing an evidence-based lower limb exercise prescription course, and based on the little poll we put on Twitter the other day, it would seem to be popular. So that's based around some of the stuff we've said here, in that how does exercise work, how does it get people better, and for me that burden of proof lies with physiotherapy. We claim for it to be a wonderful all-encompassing intervention, and if you're interested, come along to that sort of the pilot of that course, which we're going to announce at some point this week, to get our take on how exercise gets people better and help us develop it. But
we'll certainly share those links on Facebook and the Twitter page as well, so people can get access to that at any time.
Perfect.
Brilliant. Thanks a lot.
Thanks.
All right, thanks guys.
So there we have it. 2 guests always takes us into extra time. I hope it was of interest, and please shout up on social media to tell us what you agree and disagree with at TPM Podcast on Twitter and as the Physio Matters Podcast on Facebook. I'm at choose_health on Twitter and now have a Twitter page for professional discourse as Jack Chew. Brad can also be found on Twitter under the handle at Brad_Neal_07. Huge thanks to podcast sponsor Co-kinetic, who makes science pretty and digestible with regular articles and features, available by subscription and on a pay-as-you-play basis. Co-kinetic on Facebook and at SportX Journals on Twitter. And like any innovative platform, they are readily available for comments and questions on there. The Managing Patients with ITB Syndrome module is available at www.co-kinetic.com/category/ITBS for a measly £18. As I hope you can tell from this podcast, the articles reach beyond simply ITB syndrome into the applications of biomechanics, running retraining and timing of injection therapy. So for the first times ever, we encourage you to get your purses out and support this fantastic innovative resource that is co-kinetic.com, as they have a host of resources far beyond our ITB articles. So please check them out and start spreading the word of the good stuff in a world littered with nonsense. But until next time, here's Brad to see us out in our customary cheesy fashion.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.